For those of you who don't know, I'm Dr. Bill Sopchak here at the Sopchak Natural Health and Wellness Center, and today is what we're doing is every fourth Wednesday we do a Dr. Bill and Friends, and today Dr. Kari Craig is going to join us. She is here already, so she is a pelvic floor health specialist, and she originally I guess grew up, but she was from Zanesville, Ohio. Down south a little bit, and then they moved to this area about 9 years ago. She went to school at Ohio University, which is where my nephew went, and then she went to grad school in Pittsburgh at Chatham University. She started out in PT. I'll let her tell the story, but basically, why don't you just give them a little bit about yourself and tell them what brought you from PT with orthopedic people into the pelvic health range.
Sure. Thanks for having me. All right. So I have been a physical therapist for 8 years now, and graduating, I always had this little inkling that maybe this would be something I would enjoy. We learn the very, very basics of the basics in PT school. But I had actually had this patient early in my career who was having trouble with incontinence. And so I had been, helping her through some things, reaching out to a professor, and got her feeling great. And I was like, oh, I kind of like this. And so I had thought about going that route, but there were some things that kind of stopped me. So then, it was still just kind of an inkling. And then a couple of years later, I ended up having my first child, and ended up having some issues of my own. And then after that, I was like, I had received some answers from my providers that I just wasn't happy with. And I knew, I just knew there was more out there, and I knew there were more options. So that kind of just threw me into taking all the classes I could, basically doing as much rehab on myself as I could. And it was extremely successful. So from that point on, I kind of just like catapulted. And then a year ago, next week, I opened my own practice specializing in pelvic health. So yeah, not to get a little too, like I'm an open book. And so just to kind of give you a little bit of an idea of what I went through, is I actually experienced a prolapse with after the delivery of my son. And I knew something wasn't right, and I had gone in and I said, this is what I think is going on. So for anybody who might not know, prolapse it can be bowel, bladder, uterus, rectum, where they feel like they're actually falling out and they are descending into the vaginal or rectal canal. Mine was my bladder, and I went in, I was like, hey, something's not right. I think this is what's going on. And sure enough, it was. So I have had, my own personal experience to really, really be the motivation, I guess, behind really getting into this and really being the last push to doing it. No, oh my gosh, I am so sorry.
It's okay, it's all right. We said it's Dr. Bill and Friends.
Well, she's getting her walkie-talkie, so I thought I had it all out of this room. Just 1 second.
Life's little joys, right?
Right? Literally.
So how many do you have?
I have two. So now I have two. I have a 5-year-old, which was the original that kind of sent me into public health, and then a 3-year-old now. So, and she's the one who forgot her hockey-talkie, as she calls it. So yeah. So that's kind of the very, very shortened, abbreviated version of my story and what kind of brought me into pelvic health. So,
cool. So what kind of people would be drawn to somebody like you? I mean, like, what kind of symptoms might they have? How would they even know if they need to see a pelvic floor specialist,
Yep. So the common, I'll kind of give you the umbrella, just like the diagnoses I see, which would be stuff like incontinence, so bowel or bladder leakage. That's a really big one. So anybody experiencing any of this should have a pelvic health examination or evaluation. Prolapse, like I mentioned before, any sort of pelvic pain condition. So that can go into like a myriad of things. It can be simple orthopedic pain that is not resolving with traditional measures. So low back, hip, groin pain that you've done the traditional PT and it's just not working. The pelvic floor could potentially be the missing link there. To things like pain with intercourse, there are different conditions called like vaginismus, vulvodynia, interstitial cystitis, nerve issues. So if you're diagnosed with any of those things, which usually people have an idea at that point, but so pain, incontinence, prolapse, and then even men. So men who have the same sort of symptoms with either incontinence or pain, they could have difficulty with erection, difficulty with urination, chronic prostatitis might be something they're diagnosed with. So all of that is definitely somebody who would warrant an evaluation by myself. My personal opinion is I would love to be able to evaluate people on a more consistent basis as more of a wellness healthcare thing versus letting things become very symptomatic in nature. I feel like as a society, we're very reactive instead of proactive. So, when we have things like hysterectomies or we deliver children, whether vaginal or cesarean birth, when we have, hip surgeries, those sorts of things, a pelvic floor assessment would really be a wonderful adjunct to that because that's when a lot of this stuff starts to happen. We might not necessarily be symptomatic right away, but that's where the breakdown starts to occur. And then it's later on when we have, an injury somewhere else or we go through menopause that then throws those symptoms over the edge. Yeah, so that was kind of a long explanation, but yeah. Yeah, so
So what would you expect on your initial evaluation? I mean,
yeah.
history, I'm sure, but besides history, I mean, what else?
Yeah, so with the initial assessment, so depending on where they're coming in, what they're coming in for, often looks like, we do the subjective history, obviously. We sit and we chat and we get to know each other. And then we're going to jump into one of two things right away. We're either going to do like a just general like orthopedic assessment, posture assessment, lumbar, hip, make sure all of those boxes are checked, or we're going to jump into the pelvic floor right away. And the pelvic floor assessment it's got a full range of, variations depending on your comfort level. The gold standard assessment is actually a pelvic exam. So a little bit different than a gynecologic exam or prostate assessment in the sense like as far as for women, there's no speculum, there's no stirrups, there's none of that uncomfortable stuff. It's just me. So it's a digital, meaning single finger pelvic exam where we're going to look at the actual structure of the pelvic floor. So that's actually kind of a good segue just to kind of explain another big part of my evaluation is education. So I always think it's so important for people to understand what we're looking at, why we're looking at it, to really truly understand what's going on. And, I just think it's just good knowledge. So this is your pelvic floor. I forgot my good model at my office, of course. So the pelvic floor, for anybody who doesn't know, is actually a sling of muscles. So the pelvis would sit like this. This was actually my very first pelvic model I bought for myself. It is this person, it's actually quite genius. They did a drawing online and made it just a 3D model with little Velcro strips. So it kind of goes like this. So it's a very, I don't know, it's just cool. Nerd, nerd stuff. You get it. So we have the pubic bone here, butt bone here, tailbone here. This is a sling. Everything you see in this picture are pelvic floor muscles. So they literally are the bottom of the bowl of the pelvis. They have 4 major functions. They function for sphincteric control. So again, that ability to hold and to let go, both pee and poop. They have a role in stability. So if we think about the pelvis, when we think about all the things that connect into the pelvis, we have the abdominal muscles, we have the low back muscles, we have hip muscles coming up on either side and in the inner thighs. Oftentimes we can get all those balanced, but we have one missing piece, and that's where that pain or that discomfort keeps kind of coming back. And that's where the pelvic floor might be part of it. So if the pelvic floor is weak or too tight, it could be throwing off the ability of that pelvis to stay stable. Then we have support. So kind of going back to my story, and I had significant loss of support through my pelvic floor, so that's where the organ starts to prolapse. So that's another big one. And then sexual function. So in order to have pain-free, pleasurable intercourse, all of this has to contract and relax in a full, appropriate manner. Yeah, so that is what we are going to assess on that first session. Where within those kind of 4 functions could things be going awry? Is it a strength issue? Do these muscles have a lot of tone? Do they feel really spasmed? And how that could be contributing to what your symptoms are.
So if you're having a prolapse, your muscles are going to be a lot more flaccid, more soft, more non-supportive, as opposed to in spasm, or?
Not necessarily. So that's where both prolapse and incontinence tend to be thought of as like weakness issues, but they're not always. So just as in like any other muscle in the body, they can become very spasmed. And when those muscles become spasmed, they can't function to do their job because they don't have the full length. So you might have a loss of support through some of the structures, but then the muscles can't do their job because they're actually overactive, or maybe they've been working too hard and now they just can't function. Prolapse and incontinence also tend to be pressure management issues. So we have our body works as like our thorax, our mid body works as a canister. And our diaphragm and our pelvic floor respond to how we inhale and we exhale. Oftentimes with both the prolapse and incontinence issues, we are bearing down in places that should be supported through the pelvic floor. So for instance, like you might be holding your breath and bearing down as you lift up that box versus getting that good pelvic floor to abdominal support. And that's yeah, exactly. Yeah. And that's where things can just start to go awry. So it's not always a weakness thing. It can be a overactive thing too.
So does pelvic floor problems cause things like constipation too?
Absolutely. So if those muscles, again, in order for us to defecate, those muscles have to be able to let go. So if they can't let go, or there can actually be some like neural connectivity problems due to nerve compression somewhere that can decrease the muscle ability to let go in the manner they need to. So absolutely, constipation can be a big one.
Well, I would imagine even if, let's say, in my realm of the world where I'm dealing with interference in the nervous system all the time, even when you do adjustments in order to stimulate the nerve to get everything to function, if there's adhesions in those muscles, it's not going to change the muscle adhesions. That's something that would have to be done by somebody like you.
Yeah. Yeah. And that's where, like, I know we discussed a little bit, that's where like collaboration, I think with any person, any patient is just so big, because I have my skill set, you have your skill set, you know, someone else is going to have theirs. And that's what really gets good change in patients. Yeah. So 100%. I agree.
So
Yeah.
is it painful? The
It
treatment?
So depending on what you're coming in for, there is a potential for it to be uncomfortable. What I tell all of my patients, so if we use like pain with intercourse as an example, it's a very, very common one in a postpartum or postmenopausal mother or woman.
Right.
And postpartum, it could be due to a couple different factors, such as, you know, birth trauma, perineal scarring, could even be due to cesarean scarring just because of the abdominal connection. Postmenopausal, it has a lot to do with actually hormone shifts. I totally just lost my train of thought. Where was I going?
We were talking about, is it painful?
Oh, is it painful? That's right. I'm like, oh my gosh.
That's right. Trust me, I do it all the time. What's the bad thing is you walk out of the room and you got to walk back in to remember what it was that you were walking out for.
Right, exactly. I mean, mid-sentence. So those women sometimes experience pain when they come in for their assessment. But what I tell them is my goal is not to create pain with this assessment. Any information we get is good information, and we do not have to do a full assessment that first time. Because in my mind, if I create more pain in you, your body's response to that pain is going to be, yes, exactly what I don't want. More tension, more tightness, more engagement, where I need, you know, for us to really get pain to go away, we have to get that whole nervous system to calm down. We have to get those muscles to respond. So my goal is never pain, and I'm always very open. I explain everything as we go. I am constantly checking in. Obviously, I'm making eye contact and we're talking, you know, I'm explaining what's going on. And we gauge how it goes. You know, sometimes it takes 4 or 5 sessions for women to be comfortable and feel okay with doing a full assessment, and that's okay. So it really just depends, but it should, in my opinion, it should not be extremely painful.
Okay.
Like off the table kind of painful.
So I'm just going to remind everyone that you can either if you move your mouse around on their screen or whatever, you'll see a chat box and a Q&A. Feel free to ask questions either in the chat box or the Q&A, either one, and we'll get to those. So is it something that people might expect to have pain afterwards? Like, for example, would they be sore for a day or so afterwards? Like working any muscles in the shoulder or whatever?
It's possible. And I can usually gauge that based on the tension they have. So if I start to do, so some of my treatment techniques might be myofascial release, trigger point release, soft tissue massage to some of those muscles. And if they are extremely tense and I'm working on them for a while within that evaluation, I will tell people, you know, you might expect soreness, and I can usually gauge when people are going to do that. So it's absolutely possible. But I feel like as long as you warn people, they're okay with that. But yeah, it's possible, but it just depends on, you know, how they present and what their muscle tone is. And
okay.
Yeah.
So what about pregnancy? Like, would you want to see somebody before, like during their pregnancy or after their pregnancy?
All of the above. So if I had my gold standard, again, my gold standards here, but I would see somebody before their pregnancy do an evaluation before they're pregnant. So I had a baseline. Where is somebody's pelvic floor health at before any changes occur in the body? Then within their pregnancy, at some point, I would also want to evaluate, especially if something comes up like incontinence or pressure or pain. I would want to assess again. There are also a lot of things that I go through, and I've actually taken a pregnancy course and labor prep techniques and stuff for the pelvic floor specifically, and for depending on what somebody might be going through, I can give them tips and tricks on like their positioning during that time frame. And then I would want to see them again. I will see people as early as 3 to 4 weeks postpartum. We don't always do like an internal assessment at that point, but we can get things moving a lot more than people I think realize. You have to allow for that rest period, but there's also very fundamental things that you can start working on pretty early. And then, at some point actually doing a pelvic floor assessment again to make sure no issues come up. Because you're going to still, so often we get that, we're walking into that 6-week checkup after having a baby, not allowed to do anything. And then we walk out 20 minutes later and you're allowed to go run. But what happens to what happened within that 20 minutes that your muscles are now all of a sudden able to take all this load? Well, nothing. And that's where somebody should really, really be assessed, in my opinion, at least. So, yeah. Does that help?
Yeah. So, I mean, do you give exercises to do too, or are there exercises? It's kind of hard to stretch that. But as far as strengthening, I would imagine.
You mean like pelvic floor specific for pregnancy?
Anything.
Oh, yeah. I mean, it really, again, so I was the orthotherapist first, and that brain doesn't necessarily turn off, even though my specialty is in pelvic health. So to me, your pelvic floor is part of a greater picture. And if your hip range of motion is not good, or if your lumbar spine motion is not good, or if you're chronically sitting in posture like this, your pelvic floor issues might not go away. So you have to, I'm like, you got to look at the whole picture. So I sometimes, a lot of times, will find weakness in outer hips. So then we give strengthening for the outer hips. So there was actually a study back, I think it was 2018, that looked at, or was it last? I don't know, doesn't matter. It looked at outer hip strength and its support to the pelvic floor. And two of the muscles that need to be the strongest for pelvic floor support are the glute med, so the outer hip, and then some of the deeper rotators of the hip. So there are a lot of times with people that they're coming in for incontinence. Maybe we have to work on letting those muscles relax a little bit and strengthening a little bit, but also getting the hips where they need to be in terms of strength. And that makes me actually think, so one of the things that if people know about pelvic PT, one of the things they will hear is Kegels, or even their providers will tell them is, well, just do some Kegels, or pelvic PT is just going to give you Kegels. Unfortunately, that's still a norm out there. And I disagree. There's a lot of people in pain that really should not be doing Kegels. Most people, there was a study done about the ability of people to do them correctly. It was like 95% of those people did not even do them correctly if they were doing them at all. And then I would say out of 20 people, I maybe give them to one person. That's how rarely I will prescribe what is known as a Kegel. And a Kegel is just that active contraction of those pelvic floor muscles. Because there are so many other ways to strengthen the core than just that are functional, that we actually do day to day, because we're never walking around telling our pelvic floor to do what it's supposed to do, right? It needs to have that like automatic response. So there are better ways to strengthen those muscles if that is what you need. Yeah, so yeah, that's always a big one, because you still hear it so much, even though I feel like my profession is getting a little bit more well known and people are hearing about it a little bit more. But I'm still seeing all of these providers just hand people packets on Kegels and stuff like that, and then their problems don't go away, because that's just not how our body works. So,
Cool.
no, yeah.
Anybody have questions so far? Let me see what else. What about, doing an evaluation on somebody who has issues with, like, say, vaginal atrophy or something along that line, where they could be real sore, you know what I mean? Sensitive.
So we a lot of times, if somebody does have atrophy, I will communicate with their provider, and I gauge based on what the extent of it. Like if they tell me every time they have a bowel movement, they are having fissures because the skin is so sensitive,
Right.
might not go there right away. We might have to do some discussion with their provider about getting on some estrogen cream to allow us to do that.
Right.
But that's really the biggest thing there, is we just have to kind of gauge where the comfort level is, where the sensitivity is, but it's absolutely something that can be worked on and addressed, because the vaginal tissue is estrogen sensitive.
Right.
And so when we go through menopause, obviously we lose that source of estrogen. And so that's why when women go through menopause, all of a sudden they have the prolapse symptoms, or all of a sudden they have the incontinence symptoms, because that estrogen that those muscles used to be reliant on is now gone. So it kind of loses that plumpness. And so depending on what they have going on will depend on like their course of action for that. But,
what about, you said something earlier about prostatitis. What would you do for something like that?
So it's very similar. So for a male, where did my little thing go? For a male, everything like anatomically looks the same, obviously, with the exception of one hole, right? So pelvic floor muscles, these are the deeper muscles. Pelvic floor muscles, they sit exactly the same. So the only exception is where we do the assessment. So obviously with a male, there's only one way to assess those muscles, would be a rectal assessment. And what we will find is a lot of the same thing we find with the female pelvic health pain conditions, which is pelvic floor muscle overactivity. So once we assess those muscles, typically overactivity. So, and I would honestly say, for more often than not, we have individuals who have overactive muscles creating these issues rather than underactive muscles. I do get those people. But I still think, I think our body's natural ability to compensate is so good that those muscles they just have the tendency to get very tense and tight while just trying to protect the body. So, but yeah, so we would just it's the exact same thing. Then we're looking at the exact same muscles. But for chronic prostatitis, it's typically just overactive pelvic floor muscles it can create bladder symptoms, where high urgency, high frequency, it can create pelvic pain. So they'll get that.
Yeah, so just for you women who are listening, and men who are listening or will be listening, prostatitis, one of the things you tend to find with prostatitis is you're waking up in the middle of the night, a couple of times to pee. Usually that means that there's something not right, and typically that means there's an inflamed prostate. The longer that inflammation stays and the longer that continues on, yes, there are herbs that can help with it. We have some different products that work really well for that. But the longer that inflammatory response stays, the greater chance your prostate has to go from stage 1 of inflammatory response into something else, you know, into a cancerous situation or something along that line. And so, you know, something like this might be really good to help reduce that prostatitis, and then, you know, in the long term, you know, where you're at, it's so much better for you. So just thought I'd
Yeah.
throw that out there.
Yeah, for sure. And you know, there's a lot of times that people are having the symptoms of like chronic prostatitis, or they're having symptoms like women. A common one is they're always having symptoms of UTIs, but when assessments are done, everything's always negative.
Right.
And that's where pelvic floor is usually a major culprit, because the pelvic floor and how it sits within the pelvis, if it is overactive and inflamed, it can actually press on the bladder. So the bladder is muscle. It's a different type of muscle than like our bicep, but it is muscle, and it's sensitive to stretch, and it doesn't matter where that stretch comes from. So that can be stretched from a baby if you're pregnant. It can be stretched from the urine inside. It can be stretched from muscles that are really tense. So in this model, so like if we had the pelvis like this, the bladder actually sits right behind the pubic bone. Right behind the pubic bone are two of the major muscles, the attachment points of the major muscles of the pelvic floor. So if those guys are really inflamed and they're pushing on that wall of the bladder, it can give you that constant sensation of urinary urgency and frequency, which is obviously a major symptom of chronic prostatitis as well. So there's always that like false, like everybody's telling me this is what I have, but none of my tests are showing that. There's always that thing to kind of be thinking about. And same with UTIs.
So if you have a woman who's having chronic UTIs, I mean, then it could be a pelvic floor issue too.
Yeah, 100%. I want to go back at some point and take the data even from this first year of practice and see how many of my patients actually have checked the box of history of UTIs, because I know the percentage is high. Because what that indicates is, and even more than that, is a lot of those people who check the boxes will say, I always go in and I always feel like I have a UTI, and they'll give me antibiotics, but the lab work never confirms it. And part of that is because that pelvic floor is supposed to relax in order for the bladder to fully empty, and it doesn't. So then we get that an excess of bacteria within that urethra that then could potentially build up, or we get that squeezing of the muscles. So there's, I didn't really hit on this, but there's 3 layers of muscles of the pelvic floor. And the middle layer actually embeds that urethral sphincter. And so if it's really overactive and tight, it's going to have trouble letting go, but it's also going to create that like burning, stinging sensation like a really tight overactive muscle can. So yeah, that's a big one. Like I said, it's just super interesting to me to see how many people have that as part of their history, even though like growing up or just within the last 10, 15 years, they didn't really think twice about it. That it was just this annoying thing that just doesn't go away.
I have several patients that have had issues in the past. That's why I asked that. Yeah, and so I'm just thinking, since nobody's asking questions, I'm asking them. So ladies, come on, ask some questions. I've had a patient who has told me that there's like a bulge in the perineum, and I told her, I said, well, you're going to have to get on the webinar. She didn't, but anyways, you know, something like that. I mean, what could that be? What, I mean, other than like maybe a diastasis or something, or
It's probably a prolapse.
yeah.
Yeah, so we have that the perineum is, this model's not good for that, but the perineum is that opening between vaginal and anal opening, or that opening, that area between vaginal and anal opening. Oftentimes, so one of the tests we look at is actually for loss of support through the perineum. This muscle here is one of the top layers of the pelvic floor, and it's huge at supporting that perineal body. So it could be a weakness and excessive length through this muscle that we've lost support, whether or not it could have been multiple childbirths. It could be just excessive downward pressure all the time, or it could be more of prolapse of what bladder, uterus, rectum are kind of prolapsing down far enough, not far enough that you can maybe see something out of the vaginal opening, but far enough that you can kind of feel that pressure right at the perineum.
So a lot of these postmenopausal women who are having issues with prolapses, instead of having to have a sling surgery or something like that, something like what you're doing, what you do with them, could help them to avoid surgery.
100%. And even if the surgery would end up being something that had to be done in the future, you can think of it as like prehab. Like athletes go in for rehab for the knee prior to knee surgery. It'd be the same thing. The better off your musculature is before undergoing anything, the better off you're going to be. But yeah, I mean, I've had, you know, to give an example, I had a woman who came in and we tested her prolapse, and her uterus descended out of the vaginal opening. Now, I'm not going to do anything to change that ligamentous support of that the uterus needs to be held up. However, we can create better support systems so she's not constantly downward, creating that downward load. So what we did, so when she initially saw me, anytime she stood up, she would just feel this, like it felt like it was falling out, and it was. And then, so what we did is I worked with her provider to get something called a pessary. Pessary is a intrauterine or intravaginal device. There's all different kinds, but you place it intravaginally to help support whatever is prolapsing. And then we start strengthening. In her case, it was a strength issue, getting really good strength through the pelvic floor. And by the time she was done, she could not wear her pessary in standing around her house. Whereas before, the only way she could stand when we first started was to place that pessary internal. So we were able to create enough support through the pelvic floor for her to be able to do, you know, normal activities around her home. Now, if she would go work out, she would place the pessary in, or if she would go for a super long walk, she would place it in to help her. But I mean, for her quality of life went from, I don't want to move because I just feel like everything's going to fall out, to being, you know, being able to do anything she wanted. So, because she was dead set, I'm not having surgery, I will do anything to avoid it. So yeah.
So I think I'm about out of questions right now. Maybe you can tell them, well, I'll tell them right now. You guys all know, well, maybe a lot of you don't know if you're watching this later, but any of you who know where my office is, she's in the building right next to me, and she's on the first floor. And I don't know what the address is there. Do you know?
It's 7575. And I'm on the lower right side. It's technically Suite 103. If you're looking at the building, I'm on the lower right, but I use the door on the side of the building. I actually have the door in the front blocked.
Do you want to give them your phone number just in case somebody wants to call, or an email address or something like that?
I can give you both. It is 440-256-6268. And my email is Kari, it's Kari at Kare, Kare, pelvichealth.com. And I can always put those in here. I don't know if that would help.
Yeah, I was thinking about that, putting it in there, but then I'm like, wait a minute, the only people that are going to see it is the ones who are on the chat. And then there's no way to see it other than that.
Yeah. So
you can always contact our office, and we'll be happy to get you. Kari's going to give us some cards. You can always, come over here and say, hey, I just want to go see Kari, and we'll get you a card, and you can give her a buzz or whatever. So, so if nobody has any questions, Kari, you have other stuff you want to tell them?
Oh, I don't know. I think we covered a lot. I mean, I think people sometimes think it's scary because nobody wants to go to their yearly gynecology exam. So who wants to do an extra exam? But I think most people find that once they come in and they get to know me specifically, that they're pretty comfortable and pretty glad they came, because that little thing that just bothered them, or it can be very, very life altering, because you don't want to go anywhere without knowing where the bathroom is, or you don't want to do anything because you're afraid of the prolapse or whatever. And that's just, it's all stuff you don't have to live with, that I just don't think we're quite there as a society to know that we don't have to live with that stuff yet. So yeah, I just want people to know it's not as scary as it seems, and I'm not going to force anybody to do something they don't want to do. But yeah, I don't think I've really had, well, I probably wouldn't know, but I don't think I've had anybody who regrets coming in.
Very good. Very good. Well, yeah, I really appreciate your time. I mean, and think about it. I mean, I'm just thinking about it. If, I'm not a woman, but if I was, and if I had some kind of prolapsing and I could get it taken care of without having to have a surgery, to me, that would be huge. So,
and incontinence is a big one too.
Right. Yeah. Especially when you're caught, every time you laugh or cough or sneeze or anything like that. And you never know if you're going to, let loose some. So.
And that's where the Kegel thing is so big, because so many people say, well, I did that didn't work. Well, it might be a different issue.
So we had a question that says, maybe you covered it, but is there anything that we should do to stay healthy on a regular basis?
Are we talking
as far as pelvic floor health? As I'm sure that's what she's asking about, is pelvic floor health.
Yeah, that's what I would think too. So it's hard
to say, because you already said that 1 out of 20 people need the Kegel exercises, so it's not as simple as going, yeah, do your Kegels, because that's not necessarily what everybody needs. If they're already too tight, then they're going to cause a problem, and you probably have to have it evaluated to find out whether you need to do something or not.
So that's what I was going to say. So the best thing yet you can do to know where you're at is to get an assessment. Doesn't mean you have to continue with therapy or do anything, but it's also, one of my favorite things is when people reach out to me without actually having something going on, because they just want to know where they're at, and then you're going to catch something when it goes awry, or you're going to catch something before it goes wrong. So I have people who will come in for just like, hey, I just want to do a wellness check on pelvic floor health. I want to make sure everything's going well. And I'll say, okay, we need to work on this, and this to make sure this thing that we're starting to, you have a little bit high tone here. It was uncomfortable. This could be starting to be why you're starting to urinate more frequently, or X, Y, Z, or you're having a little pain with intercourse now. This could be it. So the best advice I can give is to get a baseline assessment, and then you'll have an idea of, am I on that line where one little thing is going to tip me over to having problems, or am I in a good place right now? And what can you do to kind of keep it that way? But yeah, unfortunately, it's very individualized. I mean, I feel like, yeah, I have always had trouble with that. When I get asked like, well, what is the best exercise for my hip. And I'm like, well, what's going on with you? Like, you know, I want to know all the details for every single person because everybody's different.
I was just checking to see if there's anything else came through. We got a great information. Thank
Great.
you. And great. So, so I guess if nobody else has questions, we're probably going to close down now. I want to thank Dr. Kari for coming over. We appreciate it. And hopefully you guys all got some great information. And she gave you one more time your phone number and your email address.
440-256-6268. And this is the tricky one. Kari, it's Kari at carepelvichealth.com. And care is with a K.
Kare.
Kare. Yeah, that was a play on my name. It actually started from my business name came from actually a private Facebook group I have that my aunt came up with the name for. So when I was coming up with my business, I couldn't figure out a name, and I was like, you know what? Why not? It works.
Awesome.
Yeah.
So awesome. I thank you for being here again. Next month in March with Dr. Bill and Friends, it's going to be Jamie Brankus. And Jamie is just over down the street. He's been on Dr. Oz. He's like, he looks like Jack LaLanne. He reminds me of Jack. In fact, he just wrote a book with Jack LaLanne's wife. Great guy, and I look forward to bringing him to you guys as well. So stay tuned to that. Kari, thank you so much again. And everybody have a great night. God bless, and we'll see you in a few weeks.
Thank you.
Take care.
You too.